So, welcome everybody. Hopefully you can see this opening slide. So it's great to see you all today for our meeting, our online meeting on polycystic liver disease with a Q&A session. Thank you for joining us. A few introductions quickly. So I'm Tess Harris from the PKD charity. And also joining me today is Susan Muirhead. Many of you will know Susan. She's been managing the registrations for this event and keeping in touch with you. And you know her also through support services. And we're absolutely delighted to have back again Dr. Ahmed Elsharkawy, who's a transplant hepatologist from Birmingham Trust. And he's spoken before on PLD and he's going to update us a little bit as well. As I said, there will be plenty of time for Q&A, but we do need to finish this within the hour because Ahmed does have to get away back to his clinics. We're very grateful to the National Lottery Community Fund for enabling us to hold these meetings. They are supporting our support services and all our work for the next 2 or 3 years. And finally, just to remind you that this meeting is for information only. It's not a substitute for any professional medical advice or medical examination. Always consult your own doctor, a pharmacist or other medical professional if you've got any concerns about your care or your treatments. And we're not, of course, recommending or promoting any treatment or brand in this meeting. So now I will stop my slides and invite Ahmed to share his.
Thank you, Tess, and thank you again for back. It's been a year and a half since I did a presentation to the PKD charity, about more than a year now, since the last time I spoke at the European Day. So it feels like only yesterday, to be honest. But I'm hoping you'll be able to see my slides. And apologies for those of you who attended the meeting with me before, because actually, I think really important to say that actually, in terms of polycystic liver disease, we're not a huge way forwards in many ways from where we were, say, a year and a half ago. But there have been a little bit of progress, and I think it's still important that this is really an under-recognized disease area where the symptoms of the burden of symptoms is really underappreciated by the medical community in general. And I think it's great having events like this to raise awareness, but to also enable people like yourselves to speak to people like myself, to educate me as well. So I don't see this as a one direction thing, me just talking to you. I also want to learn and hear about your experiences as well. So I want to leave plenty of time for questions. So I'm going to rattle through these slides relatively quickly. And I think it's important to say I'm going to focus on the knowns and, more importantly, the unknowns. So if we start, there are different forms of polycystic liver disease. And I think the critical thing to say is that we have PLD is a sort of overarching phrase. It just means polycystic liver disease. There is pure PLD, which is caused by different genes to those causing cysts in the kidneys, and I'll come back to that in a minute. And in those, you only need one copy of the abnormal gene by and large to cause the disease. Although actually it might be that you also need other factors later on in life. And again, I'll briefly touch on that. And then there is polycystic liver disease that occurs as part of polycystic kidney disease. And the polycystic kidney disease can either be where you have one abnormal copy of the gene, so-called ADPKD, autosomal dominant PKD. And liver cysts are said to occur in anywhere between 80 and 94% of patients. I suppose it depends on how you look for the cysts, and the more closely you look, and the more sensitive the imaging technique that you use, the more likely you are to pick up the cysts. Several genes have been identified. And then there's also obviously autosomal recessive polycystic kidney disease where you can get liver cysts as well. Oops, I'm going the wrong way, apologies. So there are essentially...
Apologies, Ahmed. Could you...
Sorry.
I apologise. Could you put your slides on slideshow?
Is it not on slideshow? Apologies.
Yeah, are you able...
It isn't where I am, but...
It's easier.
Did you see any of my slides?
I think we missed the first slide. That...
No,
Tess, I can see
that on slideshow now or not?
Yes,
I can see them all.
Yes, I can see them now.
okay. No, it's just if you could put them
Okay,
on.
all right, fair enough. Yeah, that's on full slideshow. If I move, can you see them now or not? Sometimes Zoom does this.
Still not moving.
So there should be a slide that says no. Okay, all right. Let's
Just
try
says different genes.
Yeah, that's the one, and you can see the picture there. And is that? Can you see my other slides, or can you see the full slideshow if I do that now?
We
can
can
see the
here.
ones down the side.
Yeah.
You can still see the ones on the side. Okay, right. Let me try.
But we can't read them.
I'm going to try resharing again. No, that's fine. Okay, fair enough. Let me just try again. Apologies about this. Is always Zoom does this sometimes. Okay, let's try the window. And let's try that.
Sarah, I'm laughing at your comment. Yes, we all love technology when it works, and it's the only time we like it. There's nothing worse than when you have a live audience and it's not playing game.
That's fine. Right, is that on full slideshow or not now?
Not yet.
Is it still just not yet? Okay, well, it's not just not playing game then, unfortunately.
You could try
see if
just
I do it some other
expanding the
way.
size of the slide.
Yeah, I can do that. That's fine. So I'll do that. Is that any better?
Yeah.
No? A bit better, but not ideal. Let me see if I play from the current slide. How about now? No, still showing just
Still
not full
different.
slideshow?
And what's coming up has turned into little tiny minuscule dots at the side.
Right. Well, I don't know why it's done that then. Yeah. Okay, fair enough. We'll stick with this then. Apologies about that.
Okay.
So this is a slide that shows the different genes involved in the different conditions. And as I say, I don't want to go through this in any detail. I just want to point out that actually we are starting to learn a lot more about the genes involved in both the autosomal dominant polycystic kidney disease, also recessive polycystic kidney disease, and when there's overlap with autosomal polycystic liver disease, and more importantly, where those genes are working within the cells and what they're doing. And that's important moving forward in terms of designing new treatments. So the field is expanding, our knowledge is increasing all the time. And because of the alterations in the way some of those proteins work that cause the disease, what occurs during essentially the period where a fetus is in its mother's womb is that you get formation of cyst abnormalities, as you can see here. Okay, so you get cysts forming in the liver, and then as people grow up, those cysts expand, you get cysts full of fluid, and they expand and they cause some of the symptoms. So again, it's something that we're learning a lot more about, and actually some of the mutations have now been introduced into animal models, mainly mice, and that then allows us to try and test treatments in the laboratory that might or might not make things better. So that's really what I'm trying to get across from these pictures. And this is a review article. These pictures are from a review article in Nature Reviews of Gastroenterology and Hepatology from September this year. So you can tell, you know, people are publishing things all the time and learning new things all the time. And so what you get is different severity of disease, from the very mild disease, which you only really pick up if you're looking with an ultrasound or looking with a scan, to the sort of more severe disease, where you can see here on the most right-hand side that the liver is virtually fully replaced. You know, the normal liver tissue is sort of the dark, that I suppose that's a brown color, and that's mostly replaced now with the cysts in the more severe form of the disease. Now, one of the important developments as well that's happened this year is that the European Association for the Study of Liver Disease has produced clinical practice guidelines for healthcare professionals on the management of cystic liver diseases. And this was published at the European Big Liver meeting, which happened to be in London this year in June. And this these CPGs, these clinical practice guidelines, are really, really influential and really important in terms of changing clinical practice, and they become almost a reference point for anyone in the field to go back to. And so it's great that these have been published, because actually they allow us to get the most up-to-date recommendations from the experts in the field internationally, and also allow us, and we'll come back to this, to argue for some of the treatments recommended in these guidelines that might not yet be provided by the NHS. And I'll come back to that because it's something I certainly want a bit of feedback on. So this was published, as I say, in June, and it makes loads of recommendations. The interesting thing when you actually read the recommendations is that the evidence or the data that are behind a lot of recommendations are graded between 1, where 1 is very strong evidence, the best evidence that we've got, and 5, which is expert consensus, essentially. And so it's consensus of people who are used to managing patients, but without much data and research behind it. And a lot of the recommendations have got grade evidences of 5. So it tells you there's a huge amount of work still that we need to do in terms of collecting data, in terms of learning more about the disease and what's associated with it. But cysts come in all shapes and size. And so this is a scan, essentially cutting the body up from the top to the bottom, looking into the body. Imagine if you were just scanning into the person standing in front of you and you're scanning in. So you can see here the liver. In figure A, there's a few cysts, mainly around the edge of the liver, but the liver is enlarged. To then B, where you have cysts actually in both sides of the liver, to C, where actually, again, virtually all the liver is replaced with cysts. And you can imagine that the symptoms that a patient with a liver that looks like A might be different significantly to the symptoms of the liver of the patient with C, where the C patient is going to have worse symptoms. And you can see also as well on C that the liver is pushing up past the heart, which is that structure with the big tube and the circle, and you can see, so it's pushing up against the lungs. So you can imagine why some people with polycystic liver disease also get breathless, because you're compressing the lung upwards. There are important things to state. The first is that liver cysts hardly ever result in liver failure. So in kidney cysts, they can cause kidney failure. We're all aware that a lot of patients need dialysis, and a lot of patients need kidney transplants. In the liver, you hardly ever get liver failure, less than 1% of people. But what it can do is compress, put pressure on important structures around the liver, such as the big vein, the inferior vena cava, that drains all the blood all the way back into your liver, or the portal vein, the main vein going into your liver, and that can result in certain complications, which we can talk about if people want to know more. The other thing is that cysts in the liver can bleed and become infected. There is a question I know that was submitted beforehand, is how often can liver cysts become infected? Actually, I couldn't find any data on the percentage or the chances of the liver cysts becoming infected. Partly because there is no good, what we call natural history data. So there's no good big collections of patients that we followed over time that we've gathered information and data on. Now that's going to change, and I can again come back to that in the discussion at the end. But for now, we can't give you a percentage chance of a liver cyst becoming infected, but it does happen. It can be serious and it can be difficult to treat. So how about treatments? And this is a really good scheme, and I've adopted this in the new guidelines from the European Association that I mentioned earlier. But essentially, it comes down to, are there symptoms or are there no symptoms? If there are no symptoms, there is no treatment for cysts in the liver, because it hardly ever causes liver failure, as I mentioned before. If there is symptoms, then it depends on where the cysts are, how big the cysts are, and whether or not, and how severe the symptoms are as well. So just talking through this very briefly, if we look at the figures at the bottom, let's talk about the second from the left. So you can see here there's a large singular cyst in the right side of the liver, and you can imagine that what you can do in that one is you can pop a needle in from outside the cyst. You can essentially suck out the fluid that's in the cyst, and you can inject something to cause this cyst to scar up. That's called aspiration sclerotherapy, and that can relieve a lot of symptoms. But you can see there's only one cyst, and that's a temporary treatment often for that one cyst. In the middle figure, you can see there's quite a few cysts, but they're also quite far forward. So at the top of the figure is your front of your body, the back of your figure, as you can see where your spine is the back of your body. And so what you can do is essentially what we call a fenestration operation, where often a surgeon can go in with a camera, through the keyhole camera, and can just, what they do is they essentially burn off the top of the cysts and suck out and put in a drain for a little bit of time. And what that can do is relieve all the fluid in those cysts. The problem with that is it can cause scar tissue. It can cause the liver that's left to sort of stick to the front of your tummy wall, and that can cause problems if you're going to do another procedure in the future. Or the sort of the second to the right figure, you can see that actually the cysts are all on the left side of the liver and the right side is relatively spared. And so what you can do is what we call a resection. So you remove the left side of your liver and you leave the right side. The liver is the only organ in the body that can regenerate. So you can take away up to 2/3 of your liver, and the third that's left grows back to the same, essentially the same functioning size as the whole liver would have been otherwise. Now, the other two modalities of treatment, when the cysts are much more widespread, as you can see in the figures on the extreme right and the extreme left, is that you can then think about either medical treatment or liver transplantation. And I'll come back to liver transplantation briefly in a minute. But the medical treatment, there are several agents that have been tried. Often the clinical trials are relatively small numbers. But what the EASL guidelines that I've mentioned recommend is thinking about using somatostatin analogues. Now, these are injections of hormones that occur naturally in your gut. It is recommended for people with severe symptoms in the guidelines. And there is a little bit of controversy about whether they reduce the liver volume, whether they improve symptoms, whether they cause the liver to shrink. And the answer is the studies that have been done have only been done for 6 to 12 months of treatment, have shown some benefit, but not everyone benefits. And the most important thing, and this is where I'm keen to hear some feedback, is currently these are not available to prescribe on the NHS. And so actually, if someone came to me and said, I want to try somatostatin analog to see if I can shrink my livers or make me feel better, I would have to apply for something called an individual funding request, which is a sheet that is 10 pages long. It goes to your local area commissioners, the people who pay for treatment locally. And what they will say is that this is a specialist thing and refer it back up to NHS England, who will say, this hasn't been approved by NICE, we can't provide it. And we go back around in a circle. So unless people privately pay for these treatments, they aren't available in the NHS. And I think that's where actually we need to have a discussion, because it's now recommended in the EASL guidelines, about maybe how we can change that, how we can advocate with NHS England about trying to at least get access for selected individuals for this. I know that one of my colleagues in Portsmouth has managed to get his local hospital to pay for a couple of patients. That was a struggle. He was only given access for 2 patients and told that's the only 2 you're going to get. And he was only given access for a year with the hospital itself paying. And that is not a self-sustainable, that's not a sustainable system to apply over the whole country. So again, we'll come back to that. So the type of operation or surgery offered depends on several things. And in the interest of time, I won't talk about this in detail, but you need to have a scan before we can decide about whether surgery is an option or not. And the problem is often surgery is a temporary solution, because the cysts that are there, that are left behind, because you don't often remove all the cysts, they can continue to grow. And actually, one big study suggested the complication rate after partial liver removal of up to 21%, with a death rate there of 2.7%. Any operation involving liver resection is a big operation, and it's best done in a centre used to operating on the liver rather than someone who does very few liver resections. So I've spoken a little bit about this, somatostatin analogues. They are given by injections. They are given once every 4 weeks. The main use of these drugs is actually to treat something called neuroendocrine tumors, and they are commissioned by NICE for that. And as I said, the trials have only looked at the effect of being on them for 6 months to maybe very small numbers up to 3 years. They stabilize the growth of liver cysts rather than reversing them, and the side effects can be quite significant: abdominal pain, pale stools, diarrhea. So there's not without its problems really. And here's just a rough representation of the change in liver volume in some of these clinical trials. And you can see you're reducing the liver volume by 5% at maximum. And once you've stopped the drugs, your liver tends to grow back again. So I think this is part of the problem, is that it needs to be long-term treatment. Not everyone will tolerate it. And most importantly, it's not currently provided by the NHS. There are other drugs that we can use. This drug, ursodeoxycholic acid, or UDCA, it's a synthetic bile acid. It's been shown in a small study to maybe have an effect on halting liver cyst growth in AD-PKD patients, but not PLD patients. I must say I've used it in a few selected patients. I've not been bowled over by a significant improvement in their symptoms, but that's my personal experience. And then again, one of the questions was, does tolvaptan affect liver cyst growth? And the answer is no, because the receptor that tolvaptan targets is found on cysts in the kidneys, not on cysts in the liver. So that's not a treatment that we generally recommend. So briefly, in terms of transplant, it's a treatment of last resort in many, many ways. It is curative because effectively you're removing the liver and giving someone a liver that doesn't have cysts, but it's a complicated operation. And there's a 5% chance of death in 1 year, but we do provide liver transplant for people with significant impairment in their quality of life, or if you get problems like the patient isn't able to eat, or they're on lots and lots of pain relief. And that's a judgment that we make as a transplant center, but also in consultation with the patients. And we put patients through a long assessment process that involves us discussing the risks in a very, very transparent, open way. And in a way, you are substituting one set of symptoms and medical problems for another, because after a transplant, you need to be on long-term drugs to suppress your immune system, to project rejection of your body, rejecting what is effectively a foreign organ. And they work really well, the immune suppression drugs, but they have their own problems in terms of side effects. And things like increasing your risk of diabetes, increasing your risk of high blood pressure, increasing your risk of other cancers moving forwards. And I think part of the issue is that we haven't been very good at recording symptoms in a systematic way. And there are now well-established polycystic liver disease questionnaires that people can fill in that allow clinicians like myself to look at how things are changing. But I'd like to finish with maybe a couple of things. First, having polycystic liver disease is horrible. Being bloated all the time is horrible. And there are many unseen physical and perhaps more importantly, psychological consequences from having it. And I think awareness of healthcare workers is poor. And often people don't understand enough about polycystic liver disease. And or they'll say, they'll brush off the symptoms and say, well, you just have to cope with it. There's nothing we can do. And to a certain extent, that is true, but that shouldn't stop us having conversations, seeing people with symptoms, and trying our best to mitigate those symptoms, and more importantly, trying to learn as a community more about this disease moving forward by sharing our experience, by collecting data, etc. There are lots of unanswered questions. I've put some of these in here. What's the best timing of liver transplant in someone with combined cysts and declining kidney function? What other treatments should be tried? What is the rate of growth of liver cysts? How does it differ between men and women? How does it differ between PLD and AD-PKD? We don't know enough about it, to be honest. And again, the EASL guidelines very clearly spell out where actually there are big current knowledge gaps in polycystic liver disease. And then finally, I'd like to finish by saying there is now a UK registry for polycystic liver disease. It's being run by Richard Aspinall, who I've mentioned, in Portsmouth. There are centres that are recruiting patients in Cambridge, in Sheffield, and in Birmingham. We're literally just about to hopefully open in the next month or so. And Tess will smile slightly because it's been a long time coming, but COVID interrupted things in terms of getting approvals and things, but we're nearly there. And I certainly spoke to a lady in clinic on Tuesday who was more than keen to join the registry, actually, because I think it's only by getting information, by thinking about the natural history, and the registry will involve filling in questionnaires every year to look at the burden of symptoms and correlating that with blood tests and correlating that with any imaging that we do, and it also will act as a sort of a central if you like, database of patients with the condition, so that if we do get access to clinical trials, and I've had a conversation with, you mentioned the EASL guidelines, that one of the big world experts on polycystic liver disease is Strength, who works in Holland. And Euston and I were having a discussion recently about, some of the clinical trials that he's got going open. And I hope that maybe once we've established registry, once we've got a good database of patients, we can really participate in some of the clinical trials that are coming. And on that, I shall stop sharing, and apologies about the technical issues.
Oh, thank you so much, Ahmed. And I am delighted to hear about the registry. That's a huge breakthrough for us, especially since you're adding the PLDQ. I presume it's a PLDQ questionnaire you'll be including in that?
Yeah. So it's a PLDQ questionnaire that people have to fill in annually. It can all be done remotely, actually, which is great, because a lot of our clinics are telephone clinics, so we can consent remotely. We can do the PLDQ remotely. If people have blood tests remotely, we can plug that in. So yes, hopefully it will be a good resource moving forward.
Oh, great. Well done. We have quite a few questions in the chat. Do you want to pick up those to start with? If you can see the chat.
We can do, yeah. We'll start from the top. Right, so the first bits are all about technology, so apologies about that again. So the first question is, when you say about resection and how the liver can grow back, will a liver grow to fill any empty space? So if someone has an nephrectomy, will the liver with someone with PLD grow bigger to fill the space where the kidney used to be? That's a great question. And the straightforward answer, Liz, is we don't know. We think possibly that actually you can imagine the kidney sort of almost what we call tamponading, putting pressure on the liver to prevent it growing further. We just simply don't know. We haven't had enough people who've had that and looked at their scans serially to make that judgment call. Presented at the British Association for Study of Liver Disease, and a fascinating case where actually, was it a nephrectomy? Or it was something again where the patient, I think it was a nephrectomy actually, where again the patient had the nephrectomy and the liver grew even bigger and it filled the space. So the answer is yes, it's totally possible that might be the case. And so Miranda said that's what happened to me. Yeah, okay, fair enough. Is resection still considered for Sally Lake? Is resection still considered as a treatment option in the UK? When I had my fenestration in 2018, the consultant said they would go straight to transplant as the next step because of complications from resection. It is still considered, but I think part of the issue is that the more you intervene, the more difficult doing a transplant becomes. And so actually, if your symptoms are severe enough to warrant a transplant, maybe not immediately, maybe in 1 or 2 or 3 years, then many surgeons would err on the side of not doing a resection as a next step because they don't want to make the transplant too difficult. And now let me explain that. Every time you do a tummy operation, you're left with scar tissue. In order to then remove the liver to do a transplant, you have to go through that scar tissue. Now that is possible, but it takes time. At the same time, you've got a liver from a donor that's, in the old days, sat on ice, that is deteriorating all the time. The longer it is not back into the warm environment where it's fed by blood vessels, etc., and getting nutrients. Now that's slightly changed recently because now we've got a lot of good technology that keeps organs alive by being on machines, so-called machine perfusion. But it's still, the more complicated the operation is, the more blood loss there is, the less the chances of the new liver going in of functioning well. So that's why surgeons are reluctant to do lots of different operations of polycystic liver disease if ultimately someone's going to need the transplant. I hope that makes sense. The next question, I had laminary from the NHS for 12 months. After 9 months, I rescanned and treatment was stopped because there was no reduction in cysts. My understanding was that the aim of the treatment was to halt growth, so that was a success, but it was stopped. I have now been on transplant for over 2 years. I mean, that's a very good question. And my interesting, and I think, yes, that would have been my intention, but also this is where actually symptoms are important. So I don't know whether your symptoms improved in those 9 months. I'll be really interested to hear a bit more about your experience actually on being on lanreotide as well, and where that was funded. Is it possible to answer that for Posey? I don't want to, expose you, but it would be great to get a bit of information on that specifically. All right, you're off camera, and are you willing to speak? That's great. Yeah.
Yeah, I'm willing to speak. Yeah, it was at Sheffield that I got the funding for that. And I did feel it gave me quite a bit of relief on just how full I felt all the time. I was able to breathe a bit better, could walk longer distances. So I tried to argue that it had made quite a good, not a huge difference to my quality of life, but something that made life more livable. Like, so I could have stayed on that for longer. But it was stopped quite suddenly, like, and just said, sorry, it's too expensive. We can't continue because it was supposed to reduce the size. But as I said, wasn't my understanding at the beginning. And when I looked at the research, that wasn't what the reason for having it in the first place.
Yeah, so that's what I mean. So you know, those graphs of changes in liver volumes, that's everyone in the trials. Now, obviously, there'll be people like yourself who wouldn't have had. And again, part of the issue is the trials haven't gone on long enough. They haven't gone on 4, 5, 6 years so that people can actually investigate the effect of being on it. Tolerance-wise, did you tolerate it okay, or did you have some side effects?
Yeah, it was just the first one that wasn't too pleasant afterwards. But after that, I wouldn't have known I'd had them. No, it was fine.
Okay, excellent. Okay, that's interesting to know. And actually, that goes back to maybe a piece of advocacy that we need to go to NHS England and say, well, actually, now the EASL guidelines say we should be giving this, offering this, but we're not able to because it's not funded. So yeah, okay, well, that's really interesting. Thank you for coming off camera and telling us this story. Okay, I'll carry on with some of the questions.
And
are there any other treatments on the horizon? Yeah.
Something that Posey mentioned was symptoms, and there was a really super question at the last minute about transplant assessment. Is there such a thing as a system threshold that justifies the listing for transplantation? How bad has it to get, and what are those symptoms?
So I think the answer is it is judgment. And actually, so for example, there isn't a score on a PLDQ that everyone agrees, okay, if you're that bad, if you've hit this threshold of a score, you get into transplant. Because actually most of the transplant centers don't use PLDQ. That's part of the thing, is PLDQ isn't still widely adopted. And hopefully that will change with time, partly because it's recommended in the EASL guidelines. I, having seen patients for now 10 years as a transplant hepatologist, I will use things like, okay, someone's had to give up their job. Someone's not going out because they're so tired all the time. Someone's short of breath chronically and they're not able to exercise. Someone's losing muscle mass. I mean, I think the things that really trigger transplant assessment is nutritional deficiencies as well. So you're starting to lose muscle mass, you're not able to eat. That to me is a definite indication of going ahead. But also I would use things like, someone who's using lots and lots of pain relief because they've got back pain or symptoms that are, or abdominal bloating or other things that are just really impacting their quality of life. So the answer is it's about how severe the symptoms are. It's also about the change as well. So if you're finding someone who's 2 years ago was working absolutely fine, and now actually they've had to give up work, they can't get out of the house, so I think the answer is it is subjective from the clinician, but it's also important as a patient, if you feel that that's a route you want to go down, that you advocate for yourself. And I know that shouldn't be the case, but I think it sometimes is the case that if a patient says, well, actually no, look, I've tried, I'm really suffering, I want to at least explore it, then I think that's worth it. I mean, the other thing is that size matters. So our surgeons in particular will often, and this is going to sound terrible what I'm going to say, will often say, well, the liver needs to be really large. It needs to be going down towards your pelvis, down towards the bottom end of your tummy, because of the risks associated with transplant. Now we know that volume doesn't necessarily correlate with symptoms. It does by and large, but in some people you'll have relatively small livers, really bad symptoms. In some people, very big livers, not that bad the symptoms. But so it's all a picture where we take lots of aspects to sort of decide on transplant.
And a second part, and it is something I know many of our community would perhaps be a question that would come up. Is there any risk to an existing transplanted kidney if you had a liver transplant at a later date?
Yes. So the straightforward answer is yes. Any liver transplant for anyone, not necessarily anyone, someone with a kidney transplant, involves a risk of kidney. And we generally say that you lose about 10 to 20% of your kidney function in any liver transplant. And then we put you on drugs that will affect your kidneys longer term, things like tacrolimus especially, which is a great immunosuppression drug. Everyone uses it, but it can affect the kidney moving forward. But kidney transplant recipients already are on tacrolimus. So, you know, so it's sort of a catch-22 situation. So yes, it does put it at risk. And the more difficult the operation, the more the risk is initially. 20 to 30% of people receiving a liver transplant need dialysis short-term after their transplant, and often the kidney then recovers. So yes, there is a risk, but it's a risk that we try and mitigate and manage as best we can.
And another one, and I do feel I should really have to ask this. The lady who asked couldn't manage today. Last week we had a lovely guest speaker and we were discussing family planning, etc. And the subjects of PLD came up, and IVF, which we know we start playing with our hormones. And the question arose about, is there potential that it could increase the rate of liver cysts? So that would be looking at the medication.
That's a very good question. Very good question. Yeah. And actually, it's in the EASL guidelines, that specific question about IVF. So, and I also know there was a question about progesterone. So there's no evidence that progesterone is actually associated with liver cysts. It's the estrogen. So it's the mini pill should be okay theoretically. Probably better to avoid hormones. The EASL guidelines recommend implant, so a coil essentially for contraception. In terms of IVF, obviously you're exposed to much higher doses of estrogen than you normally would be, but it's for a short period of time. So the answer is there is a theoretical risk, but we don't have the data to know whether it makes a big difference or not. The pregnancy itself, in some patients, causes the cyst to become bigger, but it's controversial. So there are different conflicting studies in the literature about what the effects of pregnancy. So I think the answer is avoid the oral contraceptive pill, the combined pill. Mini pill probably best avoided. Local contraception and IVF remains an open question, and it's about, you know, it's so sorry to be vague, but that there is no data essentially.
That's superb, thank you. And I noticed there, and I'm very much aware of the time, there is some questions in the chat, and I'm sure you will do your best to get through as many as you can.
We'll carry on for another 10 minutes.
While you're reading that, I noticed Natasha, who shared her patient story last time, has just celebrated her 4th liver transplant virtually.
Yeah, so this is for anniversary. Yes. It's good. Congratulations, Natasha. Yeah. Right, so I'll carry on. Is lanreotide a somatostatin analog? Yes. I know someone having these jabs in Scotland on NHS, different rules? Yes, essentially. The NHS in Scotland is funded differently, and often, and also, for example, drugs don't go through NICE to be approved in Scotland. They go through a different system. And so there might be different rules in Scotland that allow people to have lanreotide on the NHS. One of the questions is, are there any new treatments on the horizon? As I say, there are a couple of clinical trials starting of some new agents, but they are very small number clinical trials. None of them are running in the UK, to my knowledge, partly because the pharma companies haven't approached us. And this is part of the reason why getting a UK polycystic liver disease registry is really important, because if we can then go out and say we have a well-characterized group of patients, then we will attract clinical trials into the UK from that point of view. But nothing that I would say is likely to be available and licensed specifically for polycystic liver disease in the next, realistically, 2 to 3 years at least. So unfortunately, I can't have good news on that. Right, okay, we're going down some of these questions. Do you still consider a deroofing procedure as a way of reducing sudden discomfort? Yes, and our surgeons do them occasionally. Would egg freezing make cysts grow? Is one question. So I suppose the question is, again, it's a similar question to the IVF. It's about short-term hormone treatment to stimulate ovulation, and the answer is we just don't know. There's a possibility, but we just don't know. Okay, symptoms of quality of life. It's the knock-on effects too, like getting through other things that affect our health and mental well-being, menopause, for example. Yeah, I think that's more a comment than a question, and I agree fully with that. What are people's thoughts on intermittent fasting? I do this regularly as it helps with bloating, etc. So I think, again, and I look very carefully at these guidelines, there are very few recommendations about specific diets. There's recommendations, obviously, if people are starting to lose muscle, to think about taking small meals more often, simple common sense, I suppose, things, and also making sure you're getting enough protein. But actually, if intermittent fasting helps with bloating, then that makes, and it works, then I'm all for it. It might work for some people, might not work for other people. So I think that's important to say that.
Hello.
Natasha, did you want to say something?
Yeah, I've got a quick comment on intermittent fasting. Because on one of my other hats is, I'll turn my light off so you can see me properly. One of my other hats is menopause and perimenopause, and there's quite a lot of anecdotal evidence to say intermittent fasting in menopause is not a good idea because of the way we're changing as women. So it's just a comment. You might want to look at that bit too, because we also have to go through that too.
Yeah, that's fair enough. Yeah, no, absolutely. And obviously polycystic liver disease affects women 80% compared, 80% of polycystic liver disease patients are women compared to 20% are men. And that probably is all hormonal as well. How can we sign up for this registry, please? Well, I think the answer is you need to be being seen in one of the centres. So as I said, Portsmouth, Birmingham, I think both Sheffield and Cambridge. I'm not sure whether they're open or not, but so you need to be referred to one of the clinicians who have access to the registry, one of the principal investigators. That's the only way you can sign up, unfortunately, for now. Would the marino-coma cysts worse? Well, the answer is probably almost certainly no. Is gene therapy likely, and how far away? It's difficult to think that gene therapy is going to make a big difference because the cysts have already formed. And a lot of the gene therapy, a lot of the gene abnormalities will result in the cysts forming when you are growing up, and then something happens in adulthood. Because not everyone, number one, only 50% of people with polycystic liver disease have a known genetic abnormality. So there's lots of genes out there we haven't discovered. So that's the first thing to say. It's not like it's a one gene condition and you can target that particular gene. And then the other thing is, as I say, the cysts have already formed, so I'm not sure doing gene therapy is going to result in any specific ability to reverse or rein back the cyst growth. So I don't think gene therapy is going to be particularly successful. I'm happy to be proven wrong in the future, but that's my gut feeling. Okay. So if I carry on down these. Is debriefing liver cyst the same as fenestration? Yes, essentially. I'm having this done on Wednesday. We're going to HDU. I also have a transplanted kidney. I take it renal team will also be involved. I would hope so. I would ask that question if you've not had your surgical pre-assessment. I would ask it then. The fact that you're going to HDU suggests that they're being very cautious, which is excellent. They should be really involved. Depends where you're having, and depends whether the kidney team are in the same hospital, but I think that's fine. So I've talked about previous treatments. Marina, HRT affect liver cysts. Well, if the HRT is hormonal, then the answer is, well, HRT is hormone, it's hormone replacement therapy. So the answer is yes, it can do. Potentially, it is interesting that actually liver cyst growth tends to get worse until the menopause, and it tends to stabilize at that point in time. So actually, we do know that. So I think HRT, yes, potentially, if it could be avoided, it can be avoided. That'd be great. If you can go for topical, so for example, you can have topical, for the sake of argument, vaginal dryness is an issue, you can get topical hormones that is mainly applied locally that might not be as absorbed, and that I think will be better for polycystic patients. Okay. You mentioned back pain as criteria for transplant. Where can I put my current specialist to view this criteria? It isn't a criteria per se. It's something that we take into consideration. So if back pain is really bad, if you're requiring quite a lot of painkillers because of your back pain, then that's, again, something that we factor into the equation. If your symptoms are bad, then you could argue with your specialist, I take it might be a kidney specialist, to say, well, look, my symptoms are bad. Can you please refer me for an opinion for a liver transplant? And then have that discussion with the liver transplant center where you are referred, and explain the impact on your quality of life. And again, it's a bilateral conversation. whenever I'm speaking to someone. And it's something, so for example, what I've done in the past is thought, well, your symptoms are severe enough, I'll refer you for transplant assessment. It's not a definite you will need a transplant. It's go and have a conversation, have a conversation with the wider team, meet the anaesthetists, meet the surgeons, meet our transplant coordinators, speak to a patient who's had previous transplant, speak to a dietitian. And then some patients will come back to, well, actually, it's quite a big thing. I don't want to do it. It's not for me right now. And that's absolutely fine. So again, being assessed for transplant doesn't necessarily mean having a transplant. So I think that's important to say. What treatments are there for cyst infections is the next question. Well, because cysts are deep in the liver, because the blood supply to get enough antibiotic into the cysts is difficult, it's almost always that we give antibiotics to the vein. It's almost always that we give 6 weeks of antibiotics. It's almost always that it's heavy duty antibiotics that we give. And there are some occasions when we have to drain a cyst. That's rare if it's infected. But again, within the EASL criteria, there is some expert advice, again, very, very limited data on this, as to when, for example, people should be considered for a cyst drain, etc., etc. If you're getting cyst infections repeatedly, that's a good indication for transplant assessment. So we certainly have transplanted people because they've had problems with cyst infections. And I think that is something that is difficult to argue against. Okay. What percentage of people with PLD end up with a hugely enlarged liver is one question. So the answer is we don't really know, because we don't follow people routinely. One of the questions that came up beforehand was, should we screen for polycystic liver disease? And actually the EASL guidelines make this very clear that if you've not got symptoms, there's no point screening. So so it's mainly symptoms that drive interventions. So if you've got cysts and your liver is not particularly enlarged and you've not got any symptoms from it, then there's, in a way, this, there's nothing that needs to be done. So do you want to know whether you've got liver cysts or not? Some people do, some people don't. That's a personal choice. That's absolutely right. But there's no clear recommendation that you have to go and screen, because there's no intervention that universally applies, because not everyone has symptoms. Okay. Does milder PKD equals milder PLD? Pass. No, because actually I've got patients with very mild PKD and really bad PLD, and vice versa. There's patients with really bad PKD and very mild PLD. So the answer is they don't necessarily correlate, and we don't understand really why that is. The HRT I've given is topical gel on the skin. It's all about quality of life again, isn't it? Absolutely, yeah. And yeah, as I was saying about vaginal dryness, topical HRT is important. So thanks, Susan, for reminding people. Maybe a couple more things, and then we'll call it a day. How easy would it be to screen embryos for PLD? I wonder what I would advise my almost adult children to do when they want children. That's a very interesting question. So the answer is, you would have to do something called amniocentesis, where you actually, which people use for screening all sorts of genetic conditions. You would have to know which gene in particular you've got, and you would have to get a lab that would screen amniocentesis sample for that particular gene. But even then, having the gene doesn't necessarily mean you end up with the disease. So it's very difficult. It's not like, some of these really horrible, nasty metabolic diseases where what we call the penetrance, where if you've got the mutation, you're going to get the illness, and the illness consequences are very severe. There is so much variability in the way polycystic liver disease presents that it's difficult to be definitive about these things. So my personal, and it's a very personal thing, my personal advice is I wouldn't screen embryos, because it might be that even if they've got the gene, well, one, there's a risk of actually doing the screening of the embryos in utero. Two, there's then the uncertainty about whether or not they would get the disease, because there's probably lots of other factors that factor into the cysts growing moving forwards. Okay, having had estrogen-sensitive breast cancer, I'm on letrozole, which I understand is an estrogen suppressant, and since chemo I was put onto early menopause. My cysts have grown pretty rapidly since then. Is that to be expected? So that's interesting. So it's not just estrogen. So you've got an estrogen suppressant. So you should be that the letrozole makes things better, but your cysts have grown. So it's not just estrogen that leads to cyst growth. This is what I mean. We're still learning that you know, the recommendation is to stop the external estrogen, which effectively you've had done with being on the treatment, letrozole, but you're still getting growth, cyst growth. So it's not prevented it. Is it expected? It's not surprising. Well, is it expected? I would answer that question. With a very large liver, is it better to refer to a hepatologist or a general abdominal clinic? I would argue it's better to be referred to a hepatologist with an interest in polycystic liver disease, and the part of the issue is that there are very few of us around. Ideally, we refer to a hepatologist who works in a center where they've also got liver surgeons, because then they'll have access to that opinion. And so that would be my recommendation. Great. All right. Susan and Tess, I'll hand back over to you and we'll wrap up.
Thank you so much, Ahmed. That was great, and some wonderful range of questions that came in. Thank you for answering them all. And as you said, there's still so much that we don't know about PLD, and yeah, hopefully over time we'll gather more of that knowledge and be able to lead, you know, to stimulate some research into preventive treatments. So nobody should really have to have a liver transplant on account of having PLD. You know, that's completely wrong. Yeah.
That would be great. That would be great. Great if we got to that stage, wouldn't it? Absolutely.
Do you know, and even I was privy to a lot of the preview questions that came in from yourself as an audience, but actually even your questions and the support you gave to each other through the chat facility, it's so interesting. Thank you.
Great. So thank you very much, everybody, and thank you, Ahmed, for taking the time. We will edit the video, get it up on the website, and I think what we might also try and do is just do a summary and a Q&A of those questions and answers, which I think were incredibly useful. Might come back to you, Ahmed, for just some clarification on a few of them. And Susan will be following up everybody with a feedback form. And we hope we can run this session again, if you're willing, Ahmed, because we do have such huge interest, growing interest.
I hope I have some more information. I hope I have some new information, but yeah, no, I'm more than happy to.
Yeah, thank you. Thank you so much. Thank you, everybody, for joining us today.
Thank you very much.
Thank you.
Cheers.